So we can start our first presentation, Radial Intervention Tips and Tricks by Dr. Liang Ming Pham from Singapore.
Okay, so good morning everyone, and thanks Chairperson for the kind invite and introduction. Transradial catheterization and PCI have advantages in terms of better patient safety and comfort and a reduced rate of vascular complications compared to femoral access. Now, there are pitfalls with this radial technique, however, such as difficulty in gaining access and getting adequate guide support in the context of, for example, a tortuous vascular anatomy. However, with increasing cooperator experience, knowledge of several tips and tricks, these problems and complications can be minimized. So the next few minutes or so, we're going to discuss some tips and tricks that can be used to help both beginners and experienced operators alike to improve the learning process of transradial intervention and minimize complications. So first, the evidence. Meta trials have indicated that transradial catheterization is preferred by patients over femoral access because it's generally more comfortable, it lets them ambulate more quickly. More importantly, it also improves clinical outcomes by reducing bleeding and vascular access complications. Now, this diagram shown here is from a meta-analysis published in 2016 involving 24 RCTs and over 22,000 patients. The diagram shows that radial access is associated with better clinical outcomes in terms of all-cause death, MACE, major bleeding, and vascular complications compared to femoral access. And the guidelines, according to the European guidelines in 2018, also recommend radial access as a standard approach unless there are overriding procedural considerations. Now, the radial artery descends along the lateral side of the forearm above the radius towards the wrist, where it's palpable between the tendon of the flexor carpi radialis medially and the anterior border of the radius, where the conventional transradial access site is. Now, the practical implication of this is that wire and equipment have to transverse the radial and brachial artery into the brachiocephalic artery, encountering potential curves or twists along the way. At the wrist, the radial artery gives rise to the superficial palmar arch, anastomosing with the end of the ulnar artery at the hand to form the palmar arches. Now, the radial artery also lies in the superficial area here, making securing of hemostasis easier compared to that of femoral access. Now, generally, patient selection is critical in early success in learning transradial intervention. Early operators should start with stable patients who are relatively younger, middle-aged, larger-sized males with easily palpable radial arteries would be ideal candidates. On the other hand, elderly patients, especially those with a long history of hypertension, which may have tortuous arteries, particularly at the subclavian artery level, making entrance into the ascending aorta problematic. Small teen elderly patients in general would have smaller radial vessels, making initial access more challenging as well. It is also prudent to perform initial procedures on more straightforward anatomic situations, avoid complex lesions such as chronic total occlusions or complex bifurcations, or cases in which guide support is more difficult to obtain. Now, being proficient in vascular access is very important, especially since the radial artery is much smaller than the femoral artery. To ensure a higher success rate of first puncture, it is important to be familiar with the access technique. Check for the radial pulse carefully, identify the point of maximum pulsation. Ideal site is 1 to 2 cm proximal to the radial startup process. It is also good to position the forearm flat, fully extend the wrist to avoid kinking of the vessel. Also important to ensure adequate local anesthesia is given, otherwise the patient may fidget due to the pain. Arterial spasm may develop, making obtaining access even more difficult. The radial artery should be punctured at about 30 to 40 degrees to the horizontal to prevent the sheath from being introduced into a more distal location where the artery is smaller. Now, there are two options to achieve radial artery access as shown on the right-hand diagram, being the top figure, anterior wall puncture only, or the posterior wall puncture. Some people actually call it the true and true method. Now, in the anterior wall puncture, the needle needs to be directed more coaxially to the vessel. The success rate tends to be lower, and only the front wall is punctured, and less pulsatile flow may flow out. Now, in the below diagram, which is the true and true method, which is generally what I prefer as well, both the front wall and the posterior wall is punctured, and as the needle is withdrawn back to the artery again, a more prominent pulsatile flow can be seen coming out from the heart. Now, if the first puncture fails, there's no need to completely remove the needle as well. Operator can keep the needle inside too, and then feel for the radial pulse, followed by reassessing the direction for reinsertion. Now, if the current position of the needle is too far away, then we may have to remove the needle altogether and try somewhere more suitable. Take note that sometimes an increased pressure of the left finger on the radial artery while checking for the pulse may actually obstruct the flow itself. In such a situation, relieve the pressure slowly to reinstate the blood flow again and try repeat the puncture at a suitable site. Now, more recently, a more distal transradial access has also been proposed for even greater comfort. There are two possible sites where the radial pulse can be felt at the dorsal of the hand. One is what we call the anatomical snuff box, which is a triangular depression space on the radial dorsal aspects of the hand, showing up when the thumb is extended. Another puncture site is that of the first intercarpal space between the long extensor tendon and the second metacarpal bone. Advantages of this distal transradial access include that of greater patient comfort during the procedure. Patients with limited supination due to frozen shoulders or elbows can benefit. There's a reduced risk of ischemic complications to the hand in the event of radial artery occlusion, and potentially we can preserve the radial artery for future use, such as for repeat transradial intervention through the same route, or for patients who might need dialysis in the future, as well as preservation of the radiograph. Another tip is to know your equipment, to beware of existing equipment, such as a smaller diameter hydrophilic introducer sheath, which can potentially reduce the risk of radial artery spasm or pain. An example is the glide sheath slender system, which is a hydrophilic thin sheath. Other than having a hydrophilic coating allowing a smoother insertion, the sheath has a thin wall structure whereby the outer diameter is actually reduced by 1 French size while maintaining an inner diameter equivalent maintained. As shown in the live case earlier on, it allows a 7 French guide to be inserted through the radial approach, having better outcomes, allowing more greater patient comfort and reducing vascular bleeding risk. Yeah. In general, operators should avoid using sheath diameters that's greater than the radial artery diameter itself. Another potential equipment that can be at our disposal will be the use of sheathless guides, which negate the use of a radial introducer sheaths. These guides are less traumatic to the radial artery than the traditional guide in sheath. As alluded just now during the discussion, we mentioned about the razor effect, which is really the trauma that's induced by a mismatch between the inner diameter of the catheter and the wire, leaving a relatively sharp leading edge exposed that may injure the artery. Also, there is a potential to accommodate larger guides in the smaller radial artery in the setting of more complex interventions. Unfortunately, the sheathless guides tend to be of relatively higher cost. Another tip that I would like to consider is to respect the anatomy, beware the radial artery and its variations. In a study of 1,540 patients, radial artery anatomy anomalies were encountered in 13 to 14% of the time, and some of these anomalies, such as radial loops, can pose a serious challenge to delivering the wire and catheters. Use fluoroscopy when tactile resistance is encountered, and if necessary, use contrast injection as a guide. So this is an example of a guide wire crossing the loop, but I'm able to advance further. Another case example is that of a radial loop that's crossed using the aid of a guide wire and the support of a diagnostic catheter. In such a situation, using the catheter together to clock and counterclock, and this may straighten the loop. And once the wire and the catheter goes through, it will actually straighten out the loop and allow the rest of the catheter to advance. Now, another method is called a balloon-assisted tracking, which is another technique that can be used to overcome radial tortuosity. Now, here's how it works. We cross a tortuous segment with a standard angioplasty wire. A guide catheter could be advanced into the radial artery distal to the spasm first, and a balloon is then advanced over the wire to the tip of the catheter with the distal 2/3 of the balloon sticking out outside the guide, as shown in this right-hand side, and inflated just above the nominal inflation pressure. Now then, this entire balloon catheter assembly can be advanced over the wire, and as it moves forward, the balloon tip actually moves the wire off the artery wall, straightening out the tortuosity and allowing passage of the catheter, limiting further trauma to the vessel. This maneuver has to be performed under fluoroscopic guidance, and it's important that the patient is anticoagulated as well. Now, another common situation that we may encounter is the wire keeps going down the descending artery in the setting of a tortuous subclavian artery. An optimum view to assess the ascending artery is that of an LAO projection at 30 degrees. At this projection, there's less superposition of the different segments of aorta and opens up the aortic arc. A recognition of the position of the guide wire in either the ascending or descending aorta is then made possible. Another practical tip is to ask the patient to perform a deep inspiration with breath hold, allowing further negotiation of the subclavian artery by straightening out the angulation. Sometimes this has to be combined with a gentle rotation of the catheter with the use of a unplugged stiff wire as well. Now, do not panic if the guide support is suboptimal. You do not need to switch SS. There are various ways to improve guide support, such as increasing the active support by deep engagement of a guide. For example, in the case of a JL guide for the RCA, you can do a deeper clockwise rotation along the wire, or a rotational unplugged maneuver to make a loop in the coronary sinus such that the catheter bends in the coronary sinus and obtains support from the contralateral aortic wall, or the use of a more aggressive guide such as an unplugged left guide, or alternatively, the use of guide extension catheters or anchoring balloon technique can help as well. Sometimes the choice of guide is also influenced by the brachiocephalic anatomy. Example, you may need to use longer or larger guides if there's greater angulation between the brachiocephalic artery and the aorta. Last but not least, be familiar with complications specific to the radial access, which are listed here, such as radial artery spasm, thrombosis leading to occlusion, as well as perforation. So not uncommonly, operators may come across radial artery spasm, which limits access and delivery of equipment. Risk factors will include that related to the patient itself, younger females, smokers, the use of a larger sheath size to artery diameter, the use of more catheter exchanges, or if the patient is anxious. So sedation is also useful. Management would be the use of generous use of intra-arterial vasodilators such as nitrates, verapamil, and the use of smaller hydrophilic catheters. So in this diagram here, you can see you have a pseudo lesion before procedure and a much improved stricture of a pseudo stricture after the administration of intra-arterial GTN. Radial artery occlusion, usually asymptomatic due to a dual blood supply from the ulnar artery. And however, hand ischemia may still happen. Risk factors will include the use of a larger sheath to arterial diameter, a longer procedural time, or longer compression time. Most cases can be treated conservatively, although in severe cases, open thrombectomy may be required to achieve recolonization, and sometimes possibly a short duration of a low molecular weight heparin may be an option. Radial artery perforation is rare, but a failure to recognize can lead to a serious complications such as compartment syndrome, which requires urgent surgery. Immediate measures would be to perform a BP cuff inflation over the perforation site. Most times we recommend at least a 15 to 20 millimeters mercury above the systolic pressure for up to 10 to 15 minutes for 2 to 3 cycles. Instead of stopping the procedure, you can actually potentially cross the affected segment using a standard wire, advance the catheter through the perforated segment. This actually allows the arterial spasm to be relieved over the inserted sheath. The catheter itself actually works as an internal hemostatic device, and the perforation can actually be sealed after a while you complete the procedure. But always remember to check the vessel on the way out. Alternative options would be to use a prolonged balloon inflation to seal off the perforation, and the worst case scenario, a covered stent. So this is an angio clip showing an example of a perforation seen here in the lab. And after cycling of a BP cuff inflation, you can see that the perforation and the extravasation has much improved, and the procedure actually was continued. And after the procedure is done, we actually did an angiography to check, to make sure that the site and the perforation has healed. Another method is to use the balloon tamponade, as shown here in this right-hand diagram, to seal off the perforation. So in conclusion, PCI done via the transradial approach is now the default mode of access for most operators. Understanding of tips and tricks can potentially shorten the learning curve, increase procedural success, and reduce complications. And I'll just summarize some of the tips and tricks here. 1, patient selection is key. 2, Know the anatomy well and be familiar with your access technique. Know your equipment well. Potentially you have hydrophilic sheaths, sheathless guide at your disposal. Do not panic when a guide support is suboptimal. You can use various maneuvers, stiffer guides, or use of guide extension catheters or anchoring balloons. Last but not least, be familiar with possible complications and know how to manage them. Thank you very much. I should stop sharing.
Thank you.